So thanks very much. I think we've had two quite stimulating presentations, and I just asked the panel members prior to listen to the presentations and perhaps provide some few kind of opening reflections or comments on what they had heard, and then we would open up to particular questions. And if there were burning questions to Dr. Elrashidi in terms of his presentation, that would be open in the open session as well. So I might, and I'm going to, sorry, Caroline, I'm going to start with you down at the particular end, just because that's who I turned and glanced at first. But we'll have a time to respond to particular kind of questions. But if you had any kind of overview comments of what you heard and comments that you might have before we have the session.
Thanks, John. I would say always avoid eye contact with the moderator, actually. Would be my thought on that one. I guess, you know, as I was listening to the presentations and taking them in the context of the Alberta system and how we're looking to design a system for Alberta that works, and many of the they were great presentations and great speakers. In Alberta, we have different demographics and geography. So what works in some places doesn't necessarily work in others, but we can take the best out of what is happening in other places and apply them in Alberta. I heard in Nigel Edwards and again around scope, and I just wanted to speak to that just a little bit around scope of practice, because Dr. Swan asked an interesting question. And I think that there needs to be a real recognition that nobody's replacing anybody in this system. NPs aren't replacing GPs who aren't replacing specialists, and LPNs are not replacing RNs who are not replacing NPs. I have a grandfather who practiced medicine in World War II with the early advent of antibiotics, and his practice changed significantly with that technology. And I think there's a recognition that as technology changes, so does the work that we do as different healthcare professionals. Team came up a number of different times in the relationships of teams and how important that is to the outcomes of care. Co-location was really interesting with the specialist co-location. I'm more familiar with the co-location of social supports. Addictions and mental health specialist in primary care, which has also really demonstrated significant improvements in costs and in keeping people home and in the community. And technology I saw wasn't spoken to a lot, but virtual technology and monitoring people in their homes. And recently I've just taken a really good look at remote monitoring of prenatal and postnatal care and how effective that can be through virtual technology. So lots of many different things I think that are applicable to our environment here in Alberta.
Okay, and then I'll skip Muhamad. Although I did say I was going to ask him at one point in hearing the discussions that occur here whether or not there were reflections of how the conversation might be different or the same from his particular environment, because some things I think are similar everywhere, and then there are some contextual differences where, you know, that issue doesn't come up so much. But I'll just go down kind of the list. I'll turn to Brad.
Sure. So I think the key thing that I heard was the relationship component, and sometimes in Alberta in the past, and even right now, we focus on the technology. And Muhamad highlighted that even in a fully integrated EMR where everybody charts on the same system, they don't have much in terms of barriers of actual information sharing, that the technology is not enough alone to overcome some of those barriers. So, you know, what I heard both in Nigel and Muhammad's presentation is you have to mind the sociology as well, which is the bit of how community-based providers and specialty providers or facilities in Alberta talk to each other, how they come to mutual understanding on sharing work, passing information back and forth, and working collaboratively on the referral consultation process. So I heard that that is an area of focus that we have to pay attention to. I'm happy to hear that that was important, because I've always believed it's important, and it's behind a lot of the integration work that we're trying to do now. So I think we'll have to mind that moving forward. I do agree with what Carolyn said, which is the environment here is a little bit different. And when I think, for example, about the specialty co-location concept, I'm aware of no clinic in Alberta that will come near 100 primary care providers located in the same place. But if we look at it along a spectrum, which you referred to a couple times, we can move ourselves along that spectrum a long way from where we are right now and still realize a lot of the benefits. So I think thinking about some of these concepts as a spectrum and minding the relationships and building those relationships in communities in a more fulsome way were the things that I'll take away.
And just as a warning for people, because I know it did come up and there's a lot of discussion around the shift to community-based healthcare and its ability to be an answer to saving significant system costs is one that I might come back to with the particular kind of panelists, because I think there's great promise there and varying degrees in terms of how realistic we have to be or how ambitious we have to be, because sometimes I think there is potential there that sometimes people negate, but that's an issue that's going to be dealt with. Over to you, Kathy, who's in charge of everything, I guess, in the province of Alberta at the moment in terms of kind of reform of most of the system, but in terms of the certain leading a lot of the efforts of the shift to community-based healthcare and enhancement of primary care. And so Kathy might be able to update on some of the activities, but also some comments from the speakers that had gone forward.
Thank you. So, and maybe I'll try and explain how it is that's the case. And I do have an army and team of people, both in the ministry, but also at Alberta Health Services. Some of them have left, but I was going to acknowledge certainly a lot of my colleagues, and Catherine Todd and Francois and Ted were spending a lot of time on the phone. So just a couple of things. I think I'm in the most fortunate and unique position of spending pretty much every single day with either the associate minister or minister for various reasons. Usually we brief them up or we go to meetings. And one of the things that I find most rewarding about my job is that the minister will go out to places like homeless shelters or addiction centers for youth or various different groups to really understand what it is that Albertans are facing, and so it comes back and really has an understanding of what does it mean when we talk about integrating services, what does it mean by having access to services. And so when we put forward policies or ideas or suggestions, she's taking those to heart. And she's always said to me, just please, when you're doing this, when somebody walks through the door, could you please make sure that there's a hand waiting for them on the other side to help them guide them to the next step, because that's what we have in our community-based services today, as a little bit of silos and that non-ability to move things forward. I wanted to say that, as Carl mentioned that, I thought, what is it, if people ask me about my job, I would say, where do you fit? And in a biblical terms, it might be purgatory. It's somewhere between heaven and hell. I'm not quite sure. And we have a lot of work, but there's really four things. One is, and from what I've heard from today, is really trying to reduce those silos, get rid of them, have that integration, but in ways that also makes it easier. And what we're doing with some of the mental health work, as we've involved multiple stakeholders and like 250 people from various different groups, is it makes me aware of the fact that in our system we actually have in primary care other groups, foundations, providers that are outside some of our traditional walls that we must be paying attention to and involve them as part of that service coordination and integration. They provide a tremendous support to us in terms of trying to connect people, and so that for me is something that I'm paying attention to. And the last one I'll just mention, and this came very close to home for us in some of the work that we're doing in moving our work forward, is really paying attention to the lenses that we put onto things around gender-based analysis in our Indigenous groups and various other groups, some of our complex groups, because we tend to put them under the same umbrella and approach. And I think that that's not helpful, and we're really trying to take a very close look at our actions as we're moving forward in this to shift our thinking in community-based care to make sure that we're not mixing those groups. Thank you.
Okay. And Richard.
I feel at a real disadvantage here because I'm right-handed and couldn't take notes like everybody else.
Richard has access to health system recently. And so.
That's right. I could have done it with my left hand, but I wouldn't have been able to read my notes. Not that I can read them writing them with my right hand anyway. There are a number of questions I wanted to ask and points. I'm feeling old because I remember in the olden days, the large clinics used to function the way that Muhammad described, is that every large clinic in Edmonton, if you're from Edmonton, the Lynx Clinic, the Allen Clinic, the Baker Clinic, always had a group of family doctors and 2 surgeons, 2 obstetrician gynecologists, 2 pediatricians, 2 internists. So we sort of had that mix. And then we somehow got away from that. We stopped involving family physicians in hospitals, and hospitals became run by specialists. And so we stopped that blending and interaction. And we didn't have that opportunity for curbside consultations and discussions. And we just had a discussion at the break about now that specialists tend to congregate either with offices around within acute care facilities or together. All of the pulmonary doctors, for example, set up their practice in a particular clinic. They seem to like to interact with each other, and we've lost that interaction with primary care. And I'm very curious to know what the Mayo experience might have been, or how we can sort of reverse that desire to hang out with people from our own flock or our own tribe and be able to mix better with primary care. Interestingly, I also wanted to reiterate the point about relationships. When we have had that opportunity to interact, the relationships seem to be very productive, and I'd highlight one between our new Senior Medical Director for the Surgery Strategic Clinical Network, Dr. Jonathan White, when he actually went out to, from the Royal Alexandra Hospital, a surgeon there, went out to the primary care networks and met face-to-face with the physicians, and he learned an awful lot about what they wanted. They learned what would be helpful to the surgeons, and the end result is I think the people that they end up seeing are much more appropriate, because they see that the wait lists are way down, the family doctors are happier, the surgeons are happier, the patients are happier because they can get in much more quickly, just from simple relationship building and meeting with each other. I'd also be interested to ask Muhammad about the following, and I know someday I'm going to go to whatever the jail is that has to do with privacy and documentation, but the true curbside consult, and I've asked some of our people to look into it, and there's very, very little literature written about it, but the true curbside consult was you run into your colleague in the hallway or at the curbside and you ask him, hey, I have this patient, could you provide me a little bit of advice? And you used to have a lot of exchange that way and learn a lot, but I always get into trouble from my colleague, I'm not sure what his exact position is, but it has something to do with documentation and privacy and stuff across the hallway, who keeps saying, no, you're not even allowed to think about a patient without writing it down and documenting it, and you can't do those curbside consultations because you need to document that you've had that discussion. And it seems that we're so afraid of the tiniest bit of risk that we forego what to me seems like an awful lot of benefit. So I'd be interested in some thoughts around that.
And I might just pass that right over to Muhamad in terms of the curbside consultation, in terms of is there a necessity for documentation, and the other question, I think, I forget which one you have.
It was about this. How do we reconcile the fact that specialists have now either learned to or been trained to want to congregate with each other versus to be sort of spread out with
Were there particular kind of activities that were done to foster that kind of behavioral change that was consciously done in terms of the program?
We like to go on picnics together as a group to try and facilitate that, but not all that funny. In any case, with regard to the legal question about documentation, certainly as the primary care provider, you have the responsibility with that patient. So if I engage a specialist in a curbside consultation, I ask them, I run a question by them, the obligation falls on me. Now, in some circumstances, we'll ask the specialist to put a note in, and they're happy to do so. But when we've looked into this, the legal obligation falls on the primary care provider, and certainly reasonably so, because the curbside specialist doesn't have a pre-existing relationship. So they haven't seen that patient. So there's a limitation there. And actually in the literature, and you're right, there is a paucity on curbsides. Where it's been looked at in the hospital setting, there's concern about the specialist being liable for their recommendations when they don't have all the information. So they're not on the same electronic health record. Oh, you didn't give me all the right details. So this co-location model, again, the familiarity that's developed by having providers in close proximity and practicing essentially together helps to try and address that. But there is no legal concern, at least insofar as we've seen, that the specialists have to put in a note, sometimes we'll ask for it. About creating the collaboration, one aspect that I didn't mention as regarding our ICS neurology practice is that in the last year we've had the residents in our neurology practice now having their continuity clinic in part in the medical home with us. So they're being trained to recognize the value of collaborative partnerships. Other than that, I think you do have to look to creating incentive. Part of that is financial alignment, but I think most everybody who goes into medicine, regardless of their specialty, wants to deliver the best care possible. So I think part of this is by improving training, by essentially proof in the pudding with regard to the value of the experience, and certainly creating the alignment with regard to incentives.
And so I don't know if there's people who can come up to the mic if they have particular kind of questions. Hopefully we can have some people. Oh, Rob.
Hi, everyone. So for those who don't know me, Rob Skripnik with Alberta Health Services. You all know me. My question is more along the lines of how to do this. So, whether we're talking about the medical neighborhood or we're expanding it as both Kathy and Carolyn talked about, to other providers, maybe a health neighborhood concept, strikes me this is a very local phenomenon. And we have experience in Alberta, and as do many other jurisdictions, about big provincial initiatives falling apart under their weight. So I'd love to get a sense of the Mayo experience and also the thoughts of the other panelists about how do we implement these types of models in Alberta at scale if we have to do it at such a local level.
And I don't know who wants to take on that particular one. I know there are efforts underway, and I know I might have Kathy comment, and it's been noted by the deputy in the past forum that we had, of trying to look at our current primary care network structure and to scale it up to some extent with some kind of more robust planning at the zone level with various things. But I think Kathy and Brad might be able to kind of comment about the fact that I know some primary care networks and various things that are smaller, and there's not been great accountability sometimes through the history of what they've been asked to do, and I think that's starting to be formalized and some better coordination at scale at the zone level. But Kathy, I don't know if you have any comments on that.
Sure. So I have two thoughts on this, and it goes something like this: we should go all big and go and scale it up, and the other side of that is no, we should actually just do some small things and kind of do them well. So that's not the answer.
Do them both at the same time.
Do them both at the same time. So here's the thing. What I think we have found is that many of the pieces of the work that we're going to do going forward are actually quite interlocked. And so we will start with a foundation and a base on some things. So we are moving in the direction, and Brad can comment on this, and trying to coordinate some of the primary care networks in a way that will help deliver services in a more coordinated fashion across the province in a different way. And not that it was bad, but this is just enhancing and building a foundation. And on top of that, then there is an opportunity for us to take a look, and Carl mentioned, or maybe it wasn't Carl, I can't remember my meetings I've been at today, but we have just invested some dollars into a 17% increase in our budget into home care. And what that means, it's not just home care, it is restorative care, it is respite care, it is care for the caregivers. It's going to have a basket and a suite of things that are a little bit different. So these things will be taking place over the next period of time. In addition, we will have some work around the mental health that we have been working on, but that will be scaled into fitting into the primary care, into our advanced education streams, into education. So there's bits and pieces of pockets that are all going to be part of a puzzle that are interlinked. So scaling up, and so these will all be part of a primary community-based care that will look different, but that will be some foundational work to help us build on moving forward. So it isn't that we're going to do everything all at once, and it will be in a hopefully controlled fashion. But we've also had the situation where we've seen in mental health where I've had it, someone, we actually had a student, a very smart student working with us. There was a medical student last year, and he says, I could go into any community and I see a McDonald's and I know what kind of hamburger I'm going to get, but every time I go into a community, I really don't know what I'm going to get from for mental health services. I don't know where to go. So part of this is and it's because we do little bits of pockets of services, but we don't actually do them full scale enough to be able to articulate what it looks like. So that's why I said it's a double-edged sword for me, and I don't think there's a right answer. We're going to have to we're going to have a very clear set of outcomes, which we have in our minds, and then make sure that all of the activities that we're doing going forward over the next while line up to giving us that result, and have IHE help us with some of those kinds of questions and things.
And I do think the whole issue, and I'll pass over to Brad for some comments around the getting that locus, that local governance framework to do things. And I know a key part is that provincial standardization versus some kind of local responsiveness and innovation where things really happen, and you hopefully want the provincial standardization to help as a kind of a positive force, and not asking for standardization on 27 things, but have a few priorities that we can kind of focus on. But Brad, over to you.
So I think if we look back at our history, Alberta has 1,000 primary care clinics. Okay, so 1,000 primary care clinics for a total of, less than 4,000 docs. So if I was in Muhammad's shoes in Mayo, I would have 20 clinics. We have 1,000. And so the history of Alberta was that those 1,000 clinics also weren't networked together. They didn't talk to each other. They had no relationship. And what primary care networks have done is they've consolidated those clinics into locuses of primary care where the same kinds of supports are available, the same philosophy exists, and those docs are brought together to talk to each other, prioritize issues around integration, specialty care. The new governance framework now creates a relationship with Alberta Health Services at a zonal level, whereas the relationships even 2 to 3 years ago were not nearly as strong. Now we have a structural and a desired relationship at a zonal level. The missing piece of the puzzle, to be honest, in some instances are the community specialist groups who haven't had the same opportunity necessarily to get together and organize themselves. And so as we look to doing more in community, coordinating a community-based health system, we have to find a way to pair the readiness of the primary care groups with the readiness of the local specialty groups and the readiness of the health authority or Alberta Health Services. And so the scale you have to start with, in my mind, is where you can maintain some type of cohesion of relationship. So if you're so big, nobody knows each other and you can't facilitate conversation, you're probably dead in the water. If you're so small, where you're talking about one primary care doc and one specialist, it's almost impossible to scale. So I think the right size is where you can maintain cohesion of relationship. And as long as you have an approach to take those learnings and spread to the next group using a similar framework and approach in a province, I think we can reach full scale and spread. And by some of the changes in primary care networks and some of the governance framework changes, I think we're starting to see alignment of a bunch of pieces of the puzzle that'll make some of that possible.
And that's great. And I wanted to ask Caroline, just in terms from the nursing perspective, which is the glue that seems to hold the system kind of together in a lot of ways. But as far as the expanded role and the new role for nursing in primary care setting and community-based care, because a lot of it has been a lot of nursing care in institutional care settings, and then as well as in the community setting, a lot of the history has been public health, kind of nursing and various things. And I think there's new roles for nursing expanded in the primary care setting. And I don't know if you had any particular kind of thoughts, I'm sure you do, in terms of how that fits into the
Eye
kind of ongoing
contact
evolution.
again, right?
Yeah.
Yes, the eye contact. Okay, yes, absolutely. There's a lot of opportunity for nursing to move into the community and support physicians and support the population and the public for better health outcomes. I'd like to pick on a piece of what Kathy had talked about, and where nursing, registered nursing nurse practitioners are really boundary spanners. They work in NGOs, they work in community care organizations, they're also working in primary care in hospitals doing case management. So they span many, many boundaries that assist patients in navigating the system and improving that continuity of care, and certainly better utilizing some of their skills, so that frees up physicians' time and frees up other people's times to do the care that provides the highest value for the patients, I think is a really exciting opportunity. And that also provides space for pharmacists and other professions to really work together as a team and build those relationships throughout the community. So that's from the community into the primary care networks and into the hospitals, because that's where we're going to make wins for patients.
And Muhamad, did you have a comment?
Sure.
Yeah.
I think in terms of the medical neighborhood at Mayo, we're making inroads in terms of linking with our external partners like home health care services. We certainly have social work and integrated behavioral health and those components as well. But you're right, you have to get all of these components working together on the same page, communicating with each other in some collaborative care arrangement so that patients are effectively cared for. In the United States, we have the development of accountable care organizations. So as reimbursement models begin to shift and focus on populations as a whole, that will create incentive for the development of these kind of setup. And then as Brad kind of alluded to in terms of the number of clinics, certainly if you have an environment where you have a large number of clinics but few number of providers per each one, that's when you may leverage virtual models of or telemedicine modalities. You'd mentioned that the specialists are not as concentrated perhaps here, but if that were the case, certainly in partnership with some of those concentrated specialty groups, if they're highly referred to, having some form of telemedicine reaching out to these clinics would allow for familiarity and therefore higher yield of referrals, so that when they are sent forward for a face-to-face visit, they're the right patients getting care at the right time by the right folks. So that might be a way to kind of balance, as you said, on this integration spectrum, where if we can't do it with physical co-location, can we do it through virtual opportunities?
And just to be clear, as far because the difference in relationship, most of the people who would work in your integrated community specialist thing would be salaried employees of Mayo.
Correct. In our employee and community health practice, all the PCPs and the specialists are salaried. In our broader health system, if you recall our southeast region, most of the practitioners there are fee for service. They are compensated on productivity, and yet we still face some of the same challenges in terms of referrals from that broader network to Rochester, which is our hub for specialty care. And so even though we may have that environment, we sort of have to still figure out how, again, to create opportunities for higher yield referrals. And so there are some inroads out into the health system with some of our specialists as well.
And I know there's an emphasis on mental health through, and I was just wondering, Brad, in terms of the primary care network that you operate in, I know there's increasing emphasis on looking at mental health services, but as far as behavioral health specialists, psychologists, or psychiatrists, what is just your ability as a primary care physician to access those services out of your network?
So I think we have to remember that Alberta Health Services has been a long-time provider of community-based psychologists and therapists as well. But I think they would acknowledge, and patients would acknowledge, and primary care also acknowledges that there was a big gap between kind of what was required and what existed. And so many primary care networks then went to hire behavioral health specialists along the way and embed them into the kind of fabric of the primary care network. So, you know, I'm fortunate that in my own personal clinic, I have a behavioral health therapist, a a loaned behavioral health therapist from AHS as well, and then additionally have a social worker with a therapy background. So I have that embedded into my model, and it's a mixture, to be honest, of Alberta Health Services supports, primary care network supports, and clinic supports. And that co-location of those providers produces so much benefit. So we've talked a lot about the co-location of specialty providers, but our ability to be nimble in terms of the behavioral health specialists by having them co-located, it creates some incredible synergy. And the providers say, boy, when I have people that I'm referred from your clinic and I'm in your clinic, they actually all show up. So we know AHS actually in some parts of the province have a 40 or 50% no-show rate for behavioral health clients. In my clinic, it's about 4%. And because we have the corridor relationship, the behavioral health specialist can come and say, I'm away next week. I need you to please follow up on this patient because I'm really worried about them. And I can also go to them and say, this is somebody I can't wait in the normal wait process. I needed to get them in sooner. So we work together collaboratively, and that's just one example of the integration that PCNs have made possible. And I'm hopeful that as we move in the governance structure, there's more opportunity to embed home health, home care, as well as further mental health support, because I think the track record of when we've done that, it's been really successful.
Yeah, and I think, Rob, to your point about the fact of having local solutions, because often the half of an AHS psychologist and a PCN, people find local solutions to address those particular problems. We always have to be careful when we have a top-down standardization that we don't mess up what might have been quite useful and nimble kind of local solutions. But I did want to ask people about because there were two things. One, and I'm not sure whether through Nigel's presentation, but he did note one of the areas which did not seem to achieve particular kind of benefit or cost savings was the extended hours for at a local kind of primary care setting, which is often put out as a demand from government to have extended hours in certain settings, and so whether or not there was any kind of comment on that. But also, does the shift to community care save money overall? Or just the thoughts on that? Because I think it can save future investments, and I think it can save money. I wasn't totally in agreement with Nigel on some things, but I think it's a more complicated thought. But think about that, because I'm going to get Don just have a question first, but does this save money?
Yeah, I'm Don Philp. I'm at fellowship program in the School of Public Health, and I want to circle back on that point to a comment that Nigel made, but I want to just make a couple comments first, drawing in Muhammad's presentation. I mean, we all know that the health system is very complex. Even the President of the United States recognizes more complex than he thought. But I think we often forget that it is a system. I mean, everybody's trained in systems of human biology. We're trained in organizational theory. But when we come to act, we don't act as a system. So I think of all the good things that I've talked about in sort of integrating specialists in primary care and how you could improve the community-based system. But if you don't at the same time deal with the hospital side, and the point I want to circle back to with Nigel, he made the point that I've been hearing for 40 years. We'll never save any money because the beds are always there. They're going to be filled by somebody else. But he made the point that what happens is that the admission threshold gets lowered. So then the question to me is, if that is the answer, why aren't we controlling that admission threshold to really save some money? And to me, the companion of developing community-based alternatives is to actually put some primary care capacity in the emergency department so you don't access where you don't need to. So I'd just appreciate some comments on that, because we can do all the work on one side, but if we don't deal with the other part, the pressure is going to exert somewhere else.
Okay, no, that's good, and so I'll leave that to various people. One is about primary care. Can you deliver it out of an institutional setting, particularly kind of capacity in the emergency room? That's what you're talking about.
Have a catch there.
Right.
So if they do get through, that you can catch it. I wouldn't say put it all there, for sure not. I would not advocate that.
And the other one is the shift to community in terms of the value proposition in terms of saving money. But Richard, I don't know if you have any comments.
Sure, address both. Yeah, Don's point is really good, and we've seen exactly the same thing in Alberta as we open up more acute care beds, or when more acute care beds become available, they get filled. So if you build them, they will come. And so we use something known as a case mix index in Alberta to say how acute are the people that are in hospital. So as people get discharged or you build a new hospital, the threshold for admission decreases, exactly as Dawn said. And so the logical next step then would be, we'll have some sort of admission criteria. In the United States, they've had the diagnosis-related group. So if you have pneumonia, you're paid for by the insurer for 4 days of hospitalization. If the person stays in hospital 5 days, the hospital has to pick up the extra day. If you get them out after 3 days, the hospital makes profit. And so that seemed fine until you realize that consider pneumonia in a 30-year-old versus an 80-year-old versus a healthy, affluent 80-year-old versus a homeless street person with addictions type. So the social circumstances play a big role as well. The World Health Organization has recognized that, and they've tried to come up with a similar sort of scheme, but it sort of boils down again to having the right resources to address the issues. So it may not be the medical component of the pneumonia that needs treating, but it may be all of those other social things which we haven't set up our healthcare system to do, or we haven't integrated our healthcare system with the rest of the existing social support systems to do. So it can be a little bit complicated, but it's a good point. The other thing is in terms of integration, quite often people are admitted to hospital because you can get the imaging study, the specialist consultation right then and there in a timely fashion, which saves everybody time and money. If you didn't have that hospital bed, then you find the workaround, or you wait 3 months for the MRI and 6 months for the specialist consultation. So again, if we're able to solve some of these other system issues, we then solve some of those problems as well. The comment is also made then in terms of the shift to the community. Are we really saving money? And when I think about this, it's sort of asking the right question for the wrong reason, or the wrong question for the right reason. And so we are all concerned about costs. And quite often in government and AHS, we think about costs and reducing costs. And there's nothing wrong with that. I would say none of us want to become like Greece. But from a personal perspective, I think what we really want is we all want to be as healthy as we can be. We want to be healthy, we want to stay healthy. And that's what I think we would appreciate and want from our healthcare system. The benefit of that is that if we are healthy and stay healthy longer, then we develop less chronic disease and we need less acute care. So I think we'll achieve the same goal, sort of by a little bit, rather than tackling it from how are we going to reduce costs, is how are we going to perhaps maintain health.
Yeah. And Kathy, I don't know if any comments on because you're, I think, charged with probably saving a lot of kind of bending the cost curve in terms of shift to community, but I know Nigel had noted too, is you have the dilemma of the annual budget, where savings might be in next year's budget, or they might be in one sector of the system as opposed to everyone. So just some perspective on the goal of the community-based healthcare investment and shift, whether how that is links to bending the cost curve.
So, I think it's going to be in pockets that we're going to look at. So, for example, we're looking at the continuing care. We have a very good assessment tool, but people are often assessed when they're the sickest in the hospital, and where are they placed? Then they're in higher levels of care. So we have a big job to shift the conversation and the dialogue about what makes most sense and keeping people safely, but then doing the right assessments in the right place at the right time. So we've done some work, quite a bit of work, about how many people can you actually help support in their homes for continuing care versus in a long-term care center. Not that people aren't going to need long-term care centers, but we know that there's a lot of seniors that don't want to go there and they want to be in their own home. So we've taken a lot of look at, okay, so what is the investment we have to put in now for that return down the road? And it's a tough one. I've spent most of my career in various parts of the health system, and public health has been the hardest because some of the prevention promotion things people don't want to wait for. And those are the things that really are going to shift some of our thinking around the community-based care. And so I think we have a window here with a very dedicated group of leaders that are wanting to move forward in this direction. I think we have to support each other to get there, and I don't think it's going to be an easy road, or I'm not sure we're going to have the exact return on investments, but we're going to keep moving and trying to shift money around that we have in the pockets that we can to move forward.
Yeah. And Brad, I don't know if you have any comments on your role in bending the cost curve, except that I think there's been a strong commitment for significant investments into primary care to deliver value in other parts of the system.
Yeah, I mean, shifting care to community is not like a 1 or 2 year endeavor. I mean, it's a decade platform. You have to create the capacity and capability and gradually shift or grow the resource. So it's not something that in Alberta that we're going to do in a year and see direct benefit in a year later. And unfortunately, if we set ourselves up for that expectation, I think we'll be a little bit disappointed. Where we need to commit to that as a strategy, believing it will pay off. And part of that is because there is a queue. There's a queue for everything in Alberta, and if you get people out of hospital a little quicker, then some of those people that are in those lines flow in to get care, and it's going to take time to catch up. That being said, queues have cost issues as well. They're just not direct costs; they're indirect costs that then we absorb in other areas. And if you work in a facility, or you talk to any physician who works in a facility, there are common sense barriers to getting people out of hospital that have very little to do with how sick they are. So if I want home care to be put in on a Friday, or a weekend, I need to request it by Wednesday. If I request it Thursday, sometimes it doesn't happen till Monday. The issue Richard talked about, the only way to get an MRI or a specialty consult is put somebody in a hospital. Well, we talk about bending the cost curve or saving money. It is absolutely cheaper for that person to have not gone to the hospital, even if the overall pot stays stagnant for a while, because there are these queues. Investing in this as a philosophy, I think, will pay off in the next decade. Will it pay off in the next 3 months or 6 months? I think we might be setting ourselves up for failure if that's an expectation.
Yeah. And I think certainly that's been demonstrated in the commitment by the government to deal with, I think, what Nigel had outlined as not a draconian approach, but a phased approach to try and slowly reduce kind of funding, understanding that things take time. And Carolyn, I don't know if you had any kind of comments around nurses are going to save the system. In terms of
absolutely.
Yeah.
Along with the rest of the team, right?
Yeah.
So Dawn's comment was interesting. If you can prevent people from getting into hospital, we can probably maintain the same number of beds, but we need to, if you build them, they will come. And the same thing in continuing care. The more continuing care beds we build, the less money we're going to invest in home care and keeping people in their homes. So we really need to take a look at why do we admit people to hospital, and almost every time we admit someone to hospital, it should be seen as a failure. Or any time we admit someone into a continuing care bed, it should be seen as a failure to the system because we don't have the supports in place to have prevented that. So different way of flipping it, but I think that was a really good question, Don.
Yeah. And I don't know if there was a microphone here.
Hi. So my name is Kathy Miller, and I'm teaching nursing at MacEwan University. So this was segued right into my question, and a lot of the discussion seems to focus around the medical practitioner and the physician as sort of the keeper and the savior of all things happening in healthcare. And when we talk about nurses and nurse practitioners, they're sort of seen there as the supporter, or they will do as the physician directs. And I just wondered, a couple of years ago, there was some discussion around nurse-led clinics. And I wonder where that's at and how we might maybe better utilize this very valuable resource rather than looking at them as just a sort of adjunct or underling of the physician, because they actually are very valuable and have a lot to offer. And Carolyn's comment that no one is replacing anyone is not actually perceived that way. I mean, it is very much perceived that LPNs are taking the role of RNs, and that the RN is not really going anywhere. So I don't know if you can speak to that. That would be really great. Thanks.
And perhaps I know there is certainly a commitment in terms of the expanded role of nurse practitioners in the province, and Kathy might be able to speak. I know there is work underway, because I know the IHE were involved in doing a bit of an evaluation of it, of some nurse practitioner pilots in a number of clinics. There's 4 of them, I think, with that. And then Caroline maybe have some comments but totally take your point.
Yeah, so I actually don't have a lot about the actual pilot, sorry.
Yeah.
I don't know if anybody else here does in the room. But the intent is actually to look at various professions to full scope of practice in various settings. Now, the primary care networks actually are one of the great examples of where we do have those multidisciplinary teams, and some have different professions working in them depending on the population that they're dealing with. So some of the, particularly some of the inner city clinics, have a very different mix of professionals. We're also expanding some of the scope of our community paramedic programs. So there's I think opportunities. So there's absolutely, so there's been a commitment to look at different types of models through the nurse practitioner one, for example, and then expanding beyond that. Right now we're all in it together. We have a big agenda to move forward to get to a place where when somebody again walks in the door, they're getting the services that they want. So sometimes they might go into a physician to see the physician for a particular ailment, only we find out that in fact they're looking for mental health services, or we have a whole team of professionals that are then going through some other things like, have you been screened lately, or is your screening up to date based on the things that you need to have? And there's a whole team that help move those kinds of discussions forward. So I think it's open right now for what those models might look like.
And I know there are a number of nurse practitioner clinics under various primary care networks dealing with specific populations. But Caroline, if you had a particular
So for sure, there's they're actually demonstration, not pilot projects. So the intent is to maintain those nurse practitioner clinics moving forward. And so there's an absolute opportunity for registered nursing in the community and also in acute care. So there's a lot of information and research out there on appropriate staffing mixes in acute care. We can speak about that to start with. And there's a sweet spot for the number of RNs and the number of LPNs that provide the best patient outcomes. If you're looking into the communities, we have RNs that are leading sexually transmitted disease clinics. They are doing many different clinics out in the community, and with I'll speak to, we are expecting new regulations passed with RN prescribing will absolutely increase that capacity to improve vaccinations, to get our rates up from 75% perhaps to 95%, to take a look at wound care and home care so that we can get care to the people in the community where they live in a much faster in place. And that looks at how do we pair the different professions together so that we get the best access to patients to the care that they need when they need it. And that often is in the home, and it is where they live. And certainly the nursing community is well positioned, but again, that is with the partnership. It is with a team, and we have to figure out, and we're working and struggling, I would say as well, across the healthcare system to understand what is the best pairings of professionals to get the best care and best access for patients or our public, right, into the system so they get the best possible outcomes that they want for themselves.
Yeah. And we could continue for quite a while, but I'm going to let that continue over a bit of wine and cheese outside for people to join. Like if you could join in thanking our Alberta panel as well as our guests from Rochester and join for discussion outside. Thanks very much.